Acute compartment syndrome of the hand and forearm in the setting of hypothyroidism. So a brief background. Acute compartment syndrome, or ACS, is a surgical emergency. It results when pressure builds up within a muscular compartment from either a decrease in the volume capacity or more often volume overload within a compartment. And without prompt treatment, it will eventually lead to tissue ischemia and ultimately tissue necrosis. By far, the most common cause of ACS is fractures, accounting for about 75% or three-quarter percent of cases. After that, the second most common cause is soft tissue injury, and other notable causes include burns, crush and vascular injuries, thrombosis, reperfusion injuries, and infections. But there are also less common etiologies. Although rare, severe hypothyroidism has been associated with the development of ACS, and there are only a few documented cases of ACS due to hypothyroidism and severe mixed edema, none of which would involve symptom onset of the hand. So our case presentation: a 47-year-old male with a self-reported history of asthma and hypothyroidism presented with symptoms of acute compartment syndrome in the left hand. The patient handles seafood daily and works as a charter fishing consultant in the Galveston area. In terms of relevant past medical history, he's had multiple seafood-related infections and bilateral carpal tunnel syndrome. Notably, he had sustained 2 fishing-related injuries requiring surgical management previously. One of them was actually quite recent to the submission. He had undergone a successful left lower extremity fascia prior due to a Vibrio infection causing a beforehand due to a puncture wound from a swordfish. He had pain out of proportion to exam, pain with passive movement, pallor, and pulselessness as well. The patient's clinical presentation of ACS necessitated volar and dorsal hand compartment fasciotomies and carpal tunnel release, which we can see here in figure 3. And then one day post-operatively, he continued to have pain out of proportion to the exam of the hand, but also notably of the forearm as well. And due to the recurrence of ACS symptoms, the patient was taken for extension of the dorsal and volar fasciotomies to the forearm with subsequent skin grafting, which we can see in figures 4 and 5. However, during this operation, the intraoperative findings were inconsistent with clinical compartment syndrome. So we got a dermatology consult, and the dermatology consultation with subsequent biopsy actually suggested severe mixed edema, and endocrinology investigations yielded a TSH of 175 milligrams per deciliter and a free T4 of 0.07 milligrams per deciliter. And we can also see or note the bronzeness of his hand and forearm in the aforementioned figures as well, most notably in figure 4. And the patient then received IV levothyroxine. Within 24 hours, his symptoms ceased, and he has not had any similar recurrence of ACS symptoms since then. So in conclusion, the clinical presentation of ACS is driven by exam and by diagnostics via compartment pressures. It warrants prompt decision-making and execution, but certain clinical scenarios should be considered before surgical management, especially in the absence of common etiologies. Although rare, ACS can occur as a complication of hypothyroidism due to either thyroid hormone withdrawal, poorly controlled hypothyroidism, or undetected hypothyroidism. And as such, physicians should investigate further and rule out other etiologies if possible when encountering ACS in the absence of common etiologies such as trauma or soft tissue injury, in order to prevent unnecessary procedures, hospitalizations, and ultimately poor outcomes. And to our knowledge, there has been no previous case published regarding ACS due to hypothyroidism with symptom onset in the hand. And just to further elaborate, per our literature review, there's only 10 documented cases of this. 5 of them are bilateral lower extremity ACS. One of them was all 4 extremities, and then 2 that were just one lower extremity, and then 1 that was just one upper extremity in the setting of Hoffman syndrome, which is a hypothyroid myopathy. And that's what makes this case report so interesting, because Symptom onset was in the hand. That has not happened. The recurrence of symptoms in proximal extension following fasciotomy, that hasn't been seen in the case reports as well, hand to forearm or foot to lower leg. And there's only 2 papers noting upper extremity ACS, and only 4 papers that talk about it unilaterally. So although the bronzeness may have been noted and investigations prior could have been done, I can certainly understand the clinical decision making. And just considering the patient's past medical history and social history, occupational hazards, alternative diagnoses. He was quite literally seen for ACS due to fishing related trauma 2 months prior. And he also had a hand debridement of his left hand beforehand as well. So there was a lot pointing towards, hey, we need to do a fasciotomy because of, some of these typical causes. But again, this is one of those niche clinical scenarios where knowing about these things could have prevented perhaps an unnecessary procedure. And that's why I think it's important for physicians to know, because there are these niche clinical scenarios where knowing about these things, such as the uncommon etiologies, could have presented an unnecessary procedure. And yeah, I just think it's important for physicians to know this moving forward before, taking this sort of action, because it's easy to go through the motions. You see all these, especially with our patient, it seemed like a hook, line, and sinker. But there was also other things that maybe could have tipped off physicians. And this is just something that's not entirely known, but there are documented cases, although there are few, there still are documented cases. And I just think it's important for physicians to know moving forward, just to prevent, doing unnecessary procedures and preventing poor outcomes.